So once the decision for anticoagulation therapy is made, again, this is a lifelong therapy, you have to decide which anticoagulant is best for an individual patient. So currently, warfarin remains the mainstay. Chronic warfarin therapy is the most common anticoagulation strategy we have. And certainly it's not appropriate to select a newer anticoagulant, such as the direct-acting factor Xa inhibitors or direct thrombin inhibitors if a patient has valvular atrial fibrillation, such as a mechanical heart valve. Those patients are most appropriate for warfarin therapy. The second type of patient that's most appropriate for warfarin therapy is one with chronic kidney disease, especially patients on dialysis. The guidelines recommend against using the newer oral anticoagulants in patients that have renal dysfunction with a creatinine clearance of less than 30. Certainly there are FDA-approved dosing for patients that have creatinine clearance less than 30, but because those patients weren't enrolled in the clinical trials, the guidelines recommend really using warfarin. So warfarin is certainly most clearly appropriate for those two patients. It's still most clearly the most common drug that's being used. However, new starts for patients who have anticoagulation needs with atrial fibrillation are most commonly being selected with the newer agents. There's some appropriate reasons for that. One is that there's less monitoring in terms of monitoring the coagulation status. So these drugs are basically fixed doses, and the patient's dose is selected based upon their renal function, based upon some concomitant drug-drug interactions. Once the patient's dose has been selected, that patient requires less follow-up dosing changes. So unlike warfarin that requires monthly INRs, that would require dosing changes and prescription changes, the patient who has a newer anticoagulant wouldn't need that strategy. Another reason why the newer anticoagulants have been selected more commonly for newer patients is there's less drug-drug interactions. Although there are drug-drug interactions that it's important for pharmacists to be aware of, and there's management strategies for certain ones with dose reductions or potentially avoidance of that particular oral anticoagulant and potentially selection of another. So with warfarin, there's a long, long list, as we're very familiar with drug-drug interactions. So those are kind of the two most common reasons why they may be selected, but there's actually some good data as to why you would pick a newer anticoagulant. The most compelling of which is the reduction in the risk of intracranial hemorrhage. It's about 50% with the newer anticoagulants compared to warfarin. Now, if you have a patient with well-managed warfarin, those patients potentially would benefit less from switching from warfarin to the newer anticoagulants. But what is well-managed warfarin? Well-managed warfarin is not very common unless you have a specialized anticoagulation clinic. And despite the fact that we have clinical trials that talk about how to manage a patient, we have dosing algorithms with warfarin, at best, well-managed warfarin is, even in the United States, approximately 50% of the time the patient remains in the therapeutic range. If you look at the patients in an anticoagulation clinic, it may be 70% or higher. So if a patient has their INR consistently with warfarin in the range of 2 to 3, they may benefit less from switching to a newer oral anticoagulant, but certainly if they have many instances of having too high or too low of an INR, those patients may also benefit. Certain of the newer anticoagulants have less bleeding risk in the clinical trials than even warfarin, and again, warfarin is managed in the clinical trial setting. But when you look consistently at multiple registries from both the US and Europe, quote-unquote well-managed warfarin is still only on 50% to 70%.